Bu son derece heyecanlı oturumun yine çok önemli konularından bir tanesini tartışmaya geldi. Klinik olarak tam yanıt elde edilen hastalarda patolojik değerlendirme gerekli midir? Gerekli ise hangi yöntemin seçilmesi uygun olur? Biyopsi mi, lokal eksizyon mu, yoksa total mesorectal eksizyon mu? Bu sorunun cevabını da Sayın Profesör Doktor Geerard L Beets'ten alacağız. Please, Professor.
Good afternoon. Thank you also for the kind invitation here. Is pathologic assessment necessary in clinical complete response? So this is the skeptic surgeon who cannot believe it's really gone. How can you be absolutely sure it's gone? Because so far we've been discussing PCR, we know that, but that's proof that there's no tumor there. And generally surgeons feel uncomfortable without proof that it's gone. Over the years I've become more comfortable with not being 100% sure, and I'll try to show you why. This has been shown already. Local excision only makes sense if there was nothing there. That seems strange to me. It's like the only way you can prove that your patient is cured is to do an autopsy. Then you're absolutely sure. So why remove the thing if there's nothing there? So the assessment tools are the finger and the endoscope. These are the most important. Then there's imaging. Then there's histology. You can try to do forceps biopsy or do the excisional biopsy. But there's one even more important and more accurate assessment tool. That's being a little patient and taking some time to see what happens. We know the concept of pathological complete response, and in a lot of editorials you see we have to have confirmation of pathological complete response, but that is actually not true. A PCR is a surrogate endpoint when you're considering organ preservation. A clinical complete remission that is lasting, that is actually your endpoint that you're really interested in. At least that's what the patient is most interested in, and not so much the PCR. We know the PCR for a long time because we all had the discussions after surgery when you didn't find anything, you took out, you did an APR. Good news because these patients do very well, but maybe you didn't tell it, but you were thinking maybe this operation was not necessary, especially if the patient had post-operative complications. We were feeling quite uncomfortable. Is it rare? There's this big US database of more than 23,000 resections. Over 5,000 patients had a PCR, almost 1 out of 4, where you can consider maybe this was not necessary to give these patients these operations, all these stomas and these complications. So this is where our drive comes for organ preservation. We know PCR has a favorable prognosis. We've put this series together, and you can see the red ones are the PCR patients, the blue ones are the non-PCR. This is disease-free survival, this is overall survival. So they do remarkably better. That is not because we did not, that is not specifically because they had no tumor there left, but a PCR is a sort of a favorable prognosis. You can say that chemoradiation selects out patients who do inherently well. Why do I say that PCR is a surrogate endpoint? It's not 100% accurate. You can have false negatives. If you biopsy this, I'm sure the report will be aspecific inflammation. After having 1,000 reports of aspecific inflammation, I stopped biopsying these things. And there still can be a tumor hidden underneath, so you can have false negatives. You can have false positives. That is something we often do not realize. This is the curve of PCRs of patients who have been operated 11 to 17 weeks after the operation. If you operate a patient at this moment of time, you will find tumor cells there. It's not a PCR, and if you would have operated this patient a month later, there would have been nothing there. So finding tumor cells in a biopsy or local excision, if you do that early, does not necessarily mean that it's viable tumor. So I've already said the clinically relevant endpoint is a sustained clinical response, and I would argue to this, to promote some discussion, diagnostic local excision is a measure of impatience from the part of the surgeon. But why are we so worried? In the talks earlier this afternoon, there was local failure, local relapse, and that is a terrible thing, and we are terribly afraid of it. We don't want that, because this is what we associate with local recurrence. Terrible disease, often metastasized, terrible operations you need to do with terrible outcome. This is what we don't want, and this is what everyone's afraid of. But this is not what happens if you have a failure after watch and wait. In 2014, I believe Pat Patey was also there, there was a consensus meeting, and we said, well, after watch and wait, and 3 months later you see this tiny nodule of 2 millimeter appearing in the lumen, you treat that with your rectal resection. That's actually not a local recurrence. Let's call that differently, and we started calling it local regrowth or persistence of tumor or delayed surgery. It doesn't have the same ominous meaning as a local recurrence. And yet again, we have to ask ourselves the question, is a regrowth harmful? It can be harmful theoretically in a number of ways. If it is unresectable, if it requires big surgery, exenteration, or if you do surgery and you have an R1 resection, or if you get metastatic disease that arises from the interval after chemoradiation until the detection. I'll show you data tomorrow that we were worried initially, but none of this seems to be true in the series, non-randomized admittedly. So there are some new concepts here. Rather than PCR, it's a durable clinical complete response that you need. Time as a diagnostic tool is far better than any of the other ones. What you actually do is initially you select patients for an extended observation period. Actually, when you think, how do you treat anal cancer, this is exactly how you treat anal cancer, and you're not worried about that. Salvage surgery sounds dreadful too, so delayed surgeries, some surgeons have called it. This is the big total mesorectal excision. You can still, in our experience, do that when you have a small luminal regrowth. Of course, that is not something you need to do to prove that it wasn't there. What about forceps biopsy? Initially, we biopsied every scar and every little thing we saw, but the report was always aspecific inflammation. False negatives, of course. We had false positives. I have taken rectums out where on the biopsy there was adenocarcinoma and there was nothing there. Maybe it had disappeared. Maybe the pathologist didn't know how to interpret these radiotherapy changes. What you can see is adenomatous changes or adenocarcinoma, but if you biopsy early, I think it confuses the pathologist. These are all images of scars. This is a typical complete response. If this is quite early, Maybe, I think if you biopsy this, that's going to be adenocarcinoma, but in these, you don't know. With these, I now tend to wait, because we would not call this typical complete responders, because you still see there's something there. You could do a TME resection, you could do a local excision, but if you wait 3 months, you see this has become a scar, and there is something there, and then you decide what to do. The same with these small ulcers. We have seen that 2 out of 3 will become normal. So we don't biopsy them early. We do not biopsy at 8 or 10 weeks. So our current protocol is that we do the assessment at 10 weeks. If there's a clear residual tumor, you do a TME. If it's a complete response, you wait. If you're not sure, like these last examples, we don't do a TEM at that time, but we add another interval. So that's the test of time. You have been doing this for anal cancer for 20 years. There is a role for biopsy. This is the doctor saying to the patient, I think there's cancer, we should take it out. But in my practice, after patients who have been followed up in the watch and wait protocol, and I see something appearing, they say, doctor, you're not taking my rectum out until you're sure it's cancer. This is when I do a biopsy, when I see something coming back, appearing. So, in theory, the diagnostic local excision is there, but I don't use it. I use patience and time. I use it for therapeutic reasons. If there is a small focus that comes back, you can do a local excision. And if a patient is desperate and wants to avoid a major resection, you can do a local excision. Why? The downside of local excisions is also it doesn't come free of complications. This is a local excision that fell apart. And we have seen that the anal rectal function is worse than after watch and wait. The downside is that endoscopic follow-up is more difficult. You see these ugly images. And on MRI, the follow-up, you see all these scars. So it's a lot more difficult after local excision than after watch and wait. So I would say that routine local excision, when you think there's a clinical complete response, is not necessary. That's overkill, I would say. The critics say you should obtain more evidence on the safety. We're doing that. I'll report on that tomorrow. If you have a near complete response, yes, you can do a local excision that seems reasonable, but we favor the extended observation period. And again, we should obtain more evidence whether that is safe or not. Are we harming patients by waiting? We're not sure, but I'll give the results tomorrow, and we'll see that the risk, if anything, is very small. And again, let me remind you, this is what you've been doing for 20 years without considering any harm in anal cancer. One word on the therapeutic excision. If you have a small tumor to start off with and it doesn't go away completely, then it makes sense to do a local excision. If you start off with a big local tumor with lots of lymph nodes positive and it doesn't respond completely, then I'm not very happy with a local excision alone, because there's a high likelihood of having lymph nodes there. Then I would go for a TME resection. And this is a new thing that we've noticed. The adenomas that appear in the follow-up, it's not malignancy, but it may be the remnant of the adenoma where the tumor originated in. And these are good indications. That's typically in the scar. These are good indications for a local excision too. We biopsy this low-grade dysplasia. not sure if the pathologist is right, and 9 months later we didn't do anything, nothing was there. But you can have a low-grade dysplasia, and 3 months later this was adenocarcinoma. Either you do a local excision here, or you do a salvage TME. So local excision can be therapeutic for small tumor remnants and for residual adenomatous disease. But I wouldn't do this for large tumors originally. I would do this only for smaller tumors. I'll skip that. So I would argue to you that histology is no longer the gold standard in organ preservation if you're willing to make that change in your mind. I think observation is a good alternative. And if you have a true diagnostic dilemma in the follow-up, then you can do a local excision, or you do the excision for therapeutic regions. Thank you.